North Untapped is a proud member of the Harbinger Media Network. Last week, a bee flew into Doug Ford's mouth during a speech in which the Ontario Premier outlined his government's possible plans to further privatise public healthcare. Ford euphemistically said he thinks it is time to get creative with how healthcare is delivered and insisted that everything is on the table. Ontario's health system is currently in crisis, amid deep staffing shortages and long wait times at emergency departments. ICU nurses have warned that they are currently working at chronically short levels, leaving them unable to meet the needs of patients. And earlier this month, 6 hospitals were forced to temporarily close various departments. Meanwhile, a total of 5 million Canadians currently do not have a regular primary care provider. But health professionals and experts warn that further privatisation of the health system will only make matters worse, resulting in poorer standards, more barriers to accessing care, and allow the rich to access healthcare faster than everyone else. Responding to Ford's comments, a coalition of public health advocates recently stated, quote, "Everything is on the table to defend our public, not-for-profit healthcare system. We will not allow, without a major fight, the for-profit privatisation of Ontario's hospitals." I'm Alex Kosh, Managing Editor of The Maple, and this week to discuss the state of healthcare in Ontario and Doug Ford's possible plans for yet more privatisation, I'm pleased to be joined by Dr. Amit Arya, a palliative care physician, a board member of Canadian Doctors for Medicare, and advocate for those who live and work in the long-term care sector. Amit, welcome to the show.
Thanks you so much for having me.
So to start off, could you tell us a little bit about your work and the advocacy that you do alongside your work as well?
Yeah, I'd be happy to do that. So I work, once again, as you've spoken about, as a palliative care physician, and I work across multiple areas of the healthcare system. So I work in hospitals, I work in home care, and also in long-term care facilities. I can share with you that prior to retraining in palliative care in 2017, I actually have 10 years of experience working in family medicine. So I worked as a family physician out in the community. At this time, I'm the palliative care lead at a not-for-profit long-term care facility in Toronto called Kensington Gardens. And I also work at the Freeman Centre for the Advancement of Palliative Care at North York General Hospital in Toronto. I have faculty appointments at McMaster and U of T, and through that, I engage extensively in education for other health workers, for members of the public, to research as well. And I'm also a board member of Canadian Doctors for Medicare, which is a not-for-profit organization that advocates for what we all want, which is high quality, equitable, sustainable healthcare in Canada. And our organization provides a voice for physicians in our country who are interested in strengthening and improving our universal healthcare system. And we advocate for innovations within the system that are evidence-based, that improve access, quality, equity, and sustainability.
Is there any particular aspect of your work that makes you think that made you really inspired to get involved with defending Medicare, or has this been something that you've always been very passionate about before you became a professional in the sector?
So, I think it's to be very honest, for me, it's a bit of an evolution. And I think when you start working in the medical system, Alex, you realize that so much of what is called healthcare goes beyond, healthcare itself and what is taught in medical school, which often focuses on treatments for illnesses and diseases and sort of the biomedical model. But so much of what happens within the system is actually being driven by the system and, really failures where, for example, even if you're a physician, and we know in our country, physician care is covered under universal health care, it's covered through your health card, the prescription that physician writes might not be covered because we do not have universal pharmacare. Working in long-term care, and I can share with you, since I started practice, I've always had an interest in looking after people with disabilities, older adults. That's definitely something I'm very passionate about. Working in the long-term care system, we can definitely talk about the failures of for-profit long-term care, which were well known and well documented through decades of evidence from even before the pandemic. So that's something that I've seen with my own eyes. I've worked in the long-term care system through all the waves of the pandemic, and I think that's what's led me to this advocacy. And I dream of a system, Alex, where the system itself should not be causing more suffering for people. The system should be trying to prevent suffering in the first place.
So tell us about the current state of Ontario's healthcare system. Like, what are some of the things that you yourself are seeing, and what are you also hearing from your colleagues on the ground?
Yeah, so that's a great question. To be very honest with you, a lot of us are experiencing a lot of burnout, moral distress. And the reason for that is because things are really bad. And I've never seen things as bad as they are right now. I mean, firstly, I'm speaking to more and more people who don't have access to primary care. And you mentioned that people cannot find a family doctor. And many of the people that I'm seeing who don't have access are people who are really vulnerable, people who have complex health conditions, people who are frail and elderly, living with a disability, people living in poverty. And our entire healthcare system is based on having a functioning primary care system. As I mentioned, I also work in home care, and home care has been grossly underfunded for decades, in spite of the fact that our population was rapidly aging, and we have a huge shortage of health workers. But now, at this point in time, I'm actually seeing that shortage of health workers become even worse. And what that means, it means that more people are neglected, they're not receiving the care they deserve, but also more and more people are ending up in the emergency department due to a lack of home care. I can speak, quite a bit about long-term care, which suffered through a great humanitarian tragedy through earlier waves of the pandemic. And that's something I think which many people are now aware of, what's going on in our long-term care facilities. And many people want to see better solutions in long-term care. But I'm really sad to tell you, Alex, that I'm not seeing through my own practice or speaking through my colleagues who are working around the province any major systemic changes to fix many of the underlying issues which pre-existed the pandemic. And once again, the pandemic is not over. And then, through my practice in the hospital, I can tell you that in the media, we're seeing that there's shutdowns of hospitals, emergency rooms, and in some cases, even ICUs. And through my regular work, when I'm in the emergency department, caring for a patient, speaking to my colleagues, or even on different wards, I'm seeing huge shortages of nurses. It's sort of a regular occurrence now, whereas previously it was not to that degree. I'm seeing that in hospitals, we have more and more agency nurses who are working in the system, and that creates many different disparities. And once again, millions of dollars are going towards for-profit private agencies to supply precariously employed nurses. And really all of this combined, along with the fact that the COVID-19 pandemic is not over, we're still having people coming in with COVID, and staff shortages caused by COVID have led to this perfect storm in our healthcare system.
It really seems that each of these aspects of the crisis, the kind of cascading parts of the same, just collapse, I suppose, caused by failures. It seems like at every level of the health system. Would that be accurate to say?
Yeah, I would agree, and that's really a very important conversation to have, because we are seeing in the media, and rightfully so, a lot of conversation focused on emergency departments and hospitals, and once again, that's very important. But we have to realize that emergency rooms were not meant to be some type of sinkhole, for lack of better wording, where every problem that was untreated or underfunded outside of the hospital walls, whether it's lack of primary care, lack of housing, for example, would just end up in the emergency department. That's not what they were designed to really do. And, our healthcare system works as a circuit, right? Where really a problem in one area of the healthcare system, whether it's home care or primary care, will have cascading effects, as you mentioned, Alex, in other areas of the healthcare system as well. And sadly, I think what we're seeing now, because hospitals and emergency rooms are affected, we're really seeing the downstream effects of this terrible spiral where, neglect in primary care, home care, long-term care, a failure to address the social determinants of health is now causing problems in our hospital system.
You've already addressed, some of the root causes that are at play here. Things like underfunding, giving millions and I suppose it's billions to private corporations who are really failing on these features of the care system. Where does this all date back to? Like, what are the root causes of this current crisis, and how is the Ford government's current management of the pandemic impacting healthcare more broadly?
Right. So that's a really good question, and it's a really complex question. Maybe I'll start by talking about the root causes. And I want to be very clear that, this is not completely the fault of the Ford government. I mean, healthcare systems, across the country are under strain, and frankly, around the world, the healthcare systems are under strain. And I really think this is sort of, an issue which it can be linked to longstanding government and system failures. Of course, we're talking to the Ford government at this point in time because of the fact that they're in charge and they have responsibility to take action regardless of what previous governments may have neglected to do. Speaking about the root causes a little further, our healthcare system was always planned for efficiency. It was designed for sort of a good day. And it wasn't really designed for, a disaster type of scenario. And now, to be very honest, we're hopefully on the latter part of the seventh wave of the pandemic, so we're just getting pummeled by wave after wave of the pandemic, and that's not what our healthcare system was designed or funded to do. Specifically, when we speak about hospital beds, Canada is near the bottom of the OECD in terms of, sort of higher income countries. Canada is near the bottom of the OECD in terms of hospital beds per capita. And Ontario itself actually funds its hospitals at the lowest rate of any province in Canada. So, low funding is the result of political choices. And once again, I will emphasize this is not just the Ford government, but governments that preceded the Ford government. There's, of course, responsibility from the federal government here. And, while I'm talking all about beds, a bed in any healthcare setting is only useful if we have enough healthcare staff to look after the patients who are in those beds. And I wanted to speak especially about nurses, although of course, healthcare is provided through interprofessional teams. So it's not just nurses, but, physicians, social work, occupational therapy, recreational therapy. There's so many other skilled professions which go into providing frontline care, but nurses are really the backbone and are leaving the profession in droves. I can tell you just, a personal anecdote. I was speaking to a colleague of mine who works as a nurse in an emergency department here in Ontario, and she told me that, they were supposed to have 19 nurses in an emergency room. This is a couple of weekends ago. They were supposed to have 19 nurses working, and instead they only had 9. So this is very sadly, a regular occurrence, across our country in Ontario. And Ontario actually went into the pandemic with a shortfall of 22,000 nurses. It's now estimated we have a shortfall of 30,000 nurses. So once again, we need to do a lot more on the human resources front. And then I wanted to elaborate lastly, from my perspective, a little bit more about our aging population, which is once again, very, very important. And I wanted to tell everyone that, we talk about universal healthcare in this country and the Canada Health Act, but the Canada Health Act only covers 2 things: physician care, and it covers hospital care. And it was designed in the 1960s when, of course, our population was a lot younger. We've known that, our population is aging, and baby boomers are sort of our biggest demographic. They're aging very quickly, and they turned 75 in 2021. So once again, we've seen this coming literally for decades. And we know that with aging, people actually requires more, they require more care. But Canada actually, once again, has implemented crushing austerity measures for the elder care sector. So I'm not going to give you exact numbers, but roughly we fund our, this basket of services, home care and long-term care, about 50% less compared to other OECD countries such as Denmark, Germany, the Nordic countries. And also, the proportion of that funding is allocated incorrectly. So in all these other countries, at least 50% or more of that funding goes towards home care rather than institutionalization in a long-term care facility. Whereas in Canada, that funding that we have, once again, it's overall much less, but it proportionally goes towards long-term care facilities, and way less goes towards home care. So once again, this is obviously a travesty. And I would say that if there's one thing that we should have learned from the pandemic so far, it's that, of course, we have to do so much better to look after older adults and people with disabilities.
Yeah, and it's pretty tragic, actually, that this seemed to be getting so much attention in the public discourse in particularly the early phases of the pandemic. But it's quite scary and upsetting how quickly that seems to have slipped from mainstream political conversations, and hopefully that gets turned around pretty soon, because otherwise, some of the disastrous impacts of that will obviously only continue to get worse. So, as I mentioned at the top, the Doug Ford government, like you said, it's not entirely his government's fault, the current situation we're in. This goes back decades from previous governments. But obviously his proposed solution, it seems at this point, is going to be more privatization of the health system. So can you give us an overview of what that might look like if it was introduced in Ontario and or the rest of Canada?
Yeah, so I mean, I can speak about this from a bit of a broader lens as well, and then also speak about it from an Ontario focus. And the reason for that, Alex, is that there was an announcement today from the Minister of Health speaking about proposed changes to, how healthcare is delivered in Ontario. And I think, first of all, I wanted to break down what privatization actually means, because there's a lot of questions about, like, what is this and what are we talking about? And my two concerns that are, basically there with privatization are around two different concepts. So one is private pay healthcare. So that's sort of a situation where you, instead of using your health card, you may go to sort of a private family medicine clinic where maybe you're paying an annual or a monthly fee. You're paying a fee per use, and that, as far as I'm aware, doesn't exist in Ontario, but it exists in other provinces. So that's private pay healthcare, right? And the other one is basically when we have investor-owned, for-profit, privately owned clinics or private delivery of care. So care is being delivered, it's being funded through the public taxpayer, through the government, but it's being delivered by private for-profit corporations. So of course, I'm very alarmed at both of these options. And I wanted to also even add one more point, that neither of these options will fix the problems in our healthcare system that we've just spoken about, Alex. So, I mean, they won't fix the biggest problem, which is human resources. In fact, we will draw health workers out of the public system into the private system, and that will once again make the health worker shortages worse. So this just is, it's not the right question in my mind. It doesn't make sense, and it doesn't make sense that politicians are speaking about this. It's like we were prescribing an asthma inhaler for somebody who needs knee surgery. It's not logical. So, I mean, specifically, we're speaking about private pay healthcare. Once again, if you're going to a clinic to get surgery outside of the public system and you're paying extra, I mean, my concern is basically about equitable access, because a fundamental principle of our healthcare system here in Canada is that access should be based on need and not ability to pay. I mean, at this time, we know that there's so many people who are, seniors on pensions, people who are low income, inflation is on the rise. So many people can't afford to, pay their grocery bills or afford to pay the rent. And it seems very cruel that we're forcing people to pay healthcare, to pay for their necessary healthcare, rather than sort of fixing the public system. And I wanted to add that this will not reduce wait times. We have evidence from other countries like Australia, where they have a hybrid system with a combination of public and private pay leads, where we have this two-tier type of system or a multi-payer system. And what that means in Australia is that public pay patients waited more than twice as long for their surgeries compared to private pay patients. And also, overall, Australia's public pay patients wait longer than Canada's public pay patients for the same surgeries. So it really shows us that this doesn't work. And then the second sort of idea that when people are speaking about privatization is when public funds are used to deliver care via for-profit private corporations. And of course, that is very, very concerning. This morning, once again, the morning that we're recording this podcast, we've heard the minister saying that we might have independent clinics, which are going to be private clinics delivering care. We've yet to hear that whether these will be for-profit or not for-profit. But of course, in the for-profit model, for-profit corporations are beholden to shareholders. They're not beholden to quality of care. And it's grossly unfair to the taxpayer that, we would be subsidizing these, the profits of these corporations. It's absolutely not a fiscally conservative move, as I'm alluding to. And of course, one just needs to look at the travesty that has happened in for-profit long-term care to realize that this is the wrong direction to head in. Two very basic facts I can tell you. I know I've been talking for a while, but I think it's important, to tell you about how the for-profit or, having private for-profit corporations deliver care doesn't work. In Ontario, we know that in the decade before the pandemic, for-profit long-term care corporations siphoned away $3.8 billion in public funding away from frontline care and towards their profits. So $3.8 billion. It's a staggering amount. And we can just imagine if these corporations were instead not for profit, or they were government funded, where they did not have that incentive to pay shareholders, if all of that money went into frontline care, we wouldn't have that travesty that occurred to that degree in the earlier waves of the pandemic. And we know that actually through data and research that's been done, where if for-profit long-term care had had the same lower death rate as non-profit facilities, we would have had 1,400 fewer deaths in long-term care in 2020. So, I mean, why are we thinking about expanding private for-profit healthcare in other areas? Once again, we've seen what has happened in long-term care. So this model should not be replicated anywhere else in our healthcare system.
You know, and you've already spoken to some of these effects, but like, how does it on a kind of day-to-day basis impact the work of a health professional, working for these private corporations or having them more involved in the delivery of care? Like, what are the more like day-to-day impacts of this kind of move?
Yeah, so as a frontline health worker, who regularly sees people who are very vulnerable, people with disabilities, older, frail adults, I mean, I think it's unimaginable to sort of think of a scenario where people would have to pay to access physician care, for example, right? When I provide care, there are important exceptions, which I'll get to, but, generally when I provide care, I don't have questions about whether a patient that I'm seeing can actually afford that care. So that's just something we've normalized here in Canada, where, when you're going to see your family doctor, you're a specialist, you have to go to the hospital because you've had a heart attack or you need life-saving surgery. I mean, you don't need to pay to get that care. Once again, there are important exceptions, and I wanted to say that where, of course, if you're writing a prescription for your patient as a family doctor and your patient can't afford it, that's obviously a huge problem. As someone who works in the home care and long-term care sector, I regularly see people who are hiring extra support, whether it's private PSW or nursing services. So obviously that creates inequities in care, but this is the time that we should be working to expand our universal healthcare system. This is the time that we should be working to reduce inequities and not worsen them. So, of course, private pay healthcare is something that I feel is, very much against our moral values here in Canada. And then, secondly, when we're talking about investor-owned private for-profit entities delivering care, delivering healthcare, I can tell you that there's a lot more moral distress on the health workers working in these systems, because often they are generating their profits by oppressing the health workers and by keeping health workers poor. Specifically in for-profit long-term care, we know that these are the facilities where they're more likely to have part-time staff rather than full-time staff. They're more likely to have agency workers coming in, and they have more of a revolving door of health workers in these facilities. So once again, we know that part of the way that we have to rebuild our healthcare system is by supporting health workers. These corporations not only do not provide a good standard of care, but they also do not support their health workers. And that is essentially a problem. And, bottom line is we just can't trust private for-profit entities to provide, essential services such as healthcare. Healthcare should be viewed as a fundamental human right in Canada.
So it seems pretty clear this kind of approach is one bound for failure. So what are some real solutions to the current crisis that you and your colleagues would like to see implemented?
Yeah, that's a really good question. And I think at this time, part of the reason that privatization in some form is being proposed is because people are hungry for solutions. And I don't blame people for that. We're all hungry for solutions. And I wanted to reemphasize, we have those solutions within the public system. In the short term, I wanted to start by saying that, there are some things we can, take action on immediately to kind of stem the tide and stop the bleeding, so to say, in our healthcare system. Firstly, I think it comes down to the pandemic. So the pandemic is not over. Our governments have lost the messaging on the pandemic, where people think that COVID-19 is not a relevant disease anymore. And what this means is that we need, better messaging, for example, to remove stigma around some of the very important pandemic measures, such as indoor masking. Ideally, we should have governments provide N95 masks to everyone who wants one for free. Biden has done this in the US, so I don't know why this can't be done here in Canada. And basically, we need measures at this stage of the pandemic to keep society safe and open. So, of course, we do not need lockdowns or capacity restrictions, but what we need to reduce the spread of COVID-19 and protect our healthcare system at the same time. And as I mentioned, masking is probably one of the best measures to do that, along with paid sick days, and also encouraging people to get that third dose of the vaccine and fourth dose if they're vulnerable, elderly, or immunocompromised. So that's one thing I think we can take action on in the short term. And the second thing, which I've alluded to, is human resources. That is our biggest problem at this point in time. So here in Ontario, very unfortunately, we have this repressive and, in my opinion, sexist bill, Bill 124, which many people might have heard about, where the wages of frontline health workers, such as nurses, are capped at less than 1% per year. Wage increases are capped, and we know that inflation is much higher than 1%. We've seen that other sort of workforces, other sort of workers, such as people who work in construction, firefighters, police, are receiving much higher wage increases. So this is simply not fair that nurses who have been called heroes through the pandemic, and they really have been heroes, are effectively receiving a pay cut. So they need to repeal Bill 124. They need to give nurses a wage increase that is fair for them. And this needs to happen across the country. We need to be paying nurses for what they're worth, recognizing their expertise and their specialization in their field of work. Equal pay for equal work is another really important policy. So we often talk about that from a gender lens, but there's other parts to this where if you're working, basically if you're doing the same work within the healthcare system, you should be paid the same. So it shouldn't matter if you're part-time or full-time. It shouldn't matter, in my opinion, if you're looking after the same patient in hospital or at home or in long-term care. It shouldn't matter whether you're working for an agency or you're not working for an agency. The same work deserves the same pay. We should be providing everyone with permanent jobs, opportunities for better work-life balance, and paid sick days. So these are things that are, in my opinion, quite simple, things that can be passed through with legislation in the short term. In the long term, I think the biggest problem that we have right now, as we can see, is that governments and politicians are simply not on the same page as the public and as frontline health workers. There is some element of denial about the actual crisis. There's finger pointing going on where we see politicians at the provincial level sort of pointing their fingers at the federal government or blaming sort of past governments, and that just needs to end. I know that, when I see my patients, regardless of their political affiliation or their, the political party they might have voted for in the last election, they just want the proper care at the right time for them or their loved one. And that's really what politicians need to realize. We need a sustained commitment from politicians of all levels and all, politicians who belong to all political parties to work together to make this happen and to take action. And once again, as I mentioned, our healthcare system is a circuit. So at this time, we need to look at rebuilding our entire healthcare system. I mean, this means more investments in primary care, more opportunities for team-based approaches to care. It means things that will increase capacity in the public healthcare system, like centralized wait lists for surgery, expanding operating room schedules in order to tackle surgical backlogs. We've spoken about how universal pharmacare is really important. So some policies like that, along with publicly delivered dental care, will make a difference. Addressing the social determinants of health will also, improve the overall health of our communities, because we know that so much of what makes people sick is related to social causes, such as, housing or food insecurity. I mean, there's been lots of conversations across the country and here in Ontario about, income for people who are living with a disability. So all of these things will actually alleviate some of the strain that our system is feeling. And I wanted to just say that, just from a reflective lens, we can't afford to look back at this time in many years down the road and wish we'd done so much more to rebuild the healthcare system when it was in crisis. So once again, now is not the time for finger pointing or sort of, partisan arguments or, washing their hands of this, of the problem, denial. It's actually the time for politicians to come to the table with commitment, courage, and action.
In a recent op-ed for the Toronto Star, you and Katie Arnott wrote, and I'm quoting here, "While we undoubtedly need to invest more public funds in our healthcare system, we need to do it transparently and strategically." Can you explain a bit more about what strategic public health spending might look like?
Yeah, I think that's a really good question because a lot of people, when they're hearing these conversations about public health care, they're worried that, we're speaking about more investment and more money is needed. And while that's true in certain areas, I can tell you that there are solutions within the public healthcare system which will make the system more efficient. And these are the strategic solutions, and it will not necessarily result in increased costs. So I'm happy to explain that. I mean, first of all, we've talked about our aging population and we've spoken about home care and long-term care. So I can tell you one of the strategic solutions. Home care is much, much cheaper than long-term care because, of course, you don't have to buy land, you don't have to pay developers billions of dollars to put up these expensive buildings, and the daily cost is a lot cheaper because you don't have to pay for utilities and other expenses that occur in a long-term care facility. So we can invest a lot more in home care. In fact, we have data here in Canada that shows us that an average person in Canada who's receiving home care gets about 5 hours per week. It's very little. But even if we increase that 5 hours to 22 hours per week, it would still be cheaper than long-term care. So that shows us we have a solution right here. And I'll add that 96% of seniors, 96%, almost everyone wants to remain at home as much as they can for as long as possible. They want to avoid being sort of warehoused in this long-term care type of model. So we can invest a lot more in home care with, once again, a cheaper solution, a much better solution to allow our elders to age with dignity and respect. And of course, I'm talking about, obviously we need national standards for home care. We need to talk about publicly delivered and publicly funded home care. Very, very important. Other solutions include, I've spoken about centralized referral systems a little bit where, instead of having a family physician refer to a local surgeon, there might be a centralized referral system where, for a particular community, you would have sort of one portal where you could enter a referral and thereby referrals could be triaged a lot more appropriately. Other policies that we've spoken about, like pharmacare, actually would save the system money. So we know that about 6% roughly of hospitalizations in Canada are attributed to the fact that there's non-adherence to prescribed medications, which means that many of these patients can't afford their medications, and this costs our healthcare system as much as $1.6 billion a year. So universal publicly funded drug coverage here in Canada could actually reduce the total spending on prescription drugs by over $7 billion. Dental care is in a similar situation when people don't have affordable and timely dental care, they often go to the emergency department in desperation, which costs the system a lot more money. And in fact, we know that about 1% of all visits to the emergency department are for dental complaints. Virtual care, I would add virtual care is probably one of the silver linings of the pandemic because in some situations it has improved access to healthcare where, if you're at home or you can't go into your physician can perhaps see you, but it also has the power to connect healthcare providers quickly and easily with one another. So for example, working in long-term care, where I see many people who have very complex health conditions, people who are frail and elderly, it's definitely possible to connect people a lot better to their specialist where they don't have to go to their lung specialist or heart specialist, but they can simply be seen through virtual care. And there's research which shows that for example 49% of in-person referrals could actually be avoided by using some type of e-consult virtual care service. And this would really help primary care providers as well because they would get quicker access to specialist consults. It would reduce waiting time. So these are just some of the solutions. I can go a little bit more into this, but in the interest of time, I could tell you that there's many, many more solutions that exist within the public healthcare system, which don't necessarily need increased funding, but will make the public healthcare system more innovative and more efficient. There are some areas where we need more funding, but there's other areas where we can be more strategic, save money, and make care better.
Thank you very much for being here and for talking through this very long list of very actionable solutions that can be implemented. Where can listeners go to catch up with your advocacy and some of the solutions that you and your colleagues are proposing?
Yeah, so I think that's a great question. I think if you're up for it, you can follow me on Twitter. Definitely there's a community on Twitter very much engaged in healthcare advocacy. Many of my colleagues who I really support and learn so much from. And my Twitter ID is at Amit Arya MD. So that's at AMITARYA MD. And that's where I'm most involved. The other sort of place that I have some advocacy work that I've just started is on Instagram. So similarly, my bio there is at Amit Arya MD. So definitely I would encourage listeners to follow me there, and also we're very happy to communicate with each other. And once again, we're in this together, and I really hope that our politicians will take the necessary action as quickly as possible.
Thank you so much for your time, Amit.
Thank you so much.